Now I'll invite Professor Thomas. He'll be talking on EVO ICL patient outcomes in moderate myopia, and very interesting, his experience with lens sizing using the Lasso formula. All to you, sir.
Thank you very much. First of all, thanks, Star, for inviting me to this program here, and of course the APAO and the ESURS actually to bring us over here. I'm a consultant for Star and for several other companies who produce phakic IOLs over the years. Here's the disclosure. We have talked about all these phakic IOLs is definitely a therapy option for refractive errors, as well as we have the corneal procedures and refractive lens exchange with all the various IOLs. So my experience goes back to more than 3,000 phakic IOLs personally implanted, all types of phakic IOLs from angle supported to iris fixated to posterior chamber lens. Actually, posterior chamber was my first in 1999, which was the ICL followed by PRL, and most recently we're doing this. I show you a study which we published in the peer-reviewed literature, 5-year result, as one of my fellows, first author, Krzysztof Lwowski. We actually had a -10 diopter myopia going up to -4.5, so half a diopter at our outcome. The loss with surgery was 1.9 per year. Rare cataract formation, this was 0.8%. This was only 2 eyes in this series. And I think that with the central aqua flow, we have really solved this problem of cataract formation in the ICL. The ESURS guidelines in progress, actually at the moment, you will see them at the Copenhagen meeting. Indications actually go from -1 diopter with an ACD depth of 2.8 millimeters, for hyperopia from 1 diopter with 3 millimeters of ACD depth, astigmatism of starting by half a diopter, and predictability and safety is there higher predictability than LASIK, PRK, KLEX in the high myopic patients above -6 diopter. And it seems safe, but limited evidence regarding predictability, safety of hyperopia and astigmatism. Why I put this here, this is a peer-reviewed literature, and the document is more than 300 pages long, where we really investigated this. Making a personal statement, I correct all astigmatism from half a diopter with the ICL, and approximately I have 70% of toric ICLs which I implant at the moment. And I start basically from all this area down there. This is the German guideline, which is also, you find it in the literature, published in English actually, the ophthalmology. And there our application area starts from -1 diopter, basically up to the limit where we can go. Hyperopia +1, astigmatism, toric or ICL, as I pointed out. The topic of measurement, I think it becomes very important. ACD measurements, for all of you, understand that you don't take the IOL master and go for the epithelium. You have to look at the real anterior chamber. That's from endothelium to the crystalline lens. Type of phakic IOL is important. Avoid contact with the natural lens. Long-term healthy eye. Recommended minimum, I already touched this. And IOL positioning and vaulting is very important if you have a sulcus fixated. And the recommended vault is between 250 to 750 microns. We can discuss this in a minute. Lens size selection. Usually you do measurement, positioning, stability, and sizing is important. And what we all take is the white-to-white measurement. OCT, Scheimpflug, R-scan inside the Reinstein device is there for doing this. Individual variability, we all know that, and the measurement consistency is, of course, important. Complementary measurements are there. And you can see this here as a complementary measurement for the white-to-white importance for posterior chamber lens. You can see these here. I put other posterior chamber lens as well on this topic. And you can see here the optical diameter. They actually go in sizing. So myopia is here for hyperopia, and you can see the measurements. Let me take a couple, this last 3 minutes, ICL power calculation. This is from the company. You have a nice nomogram where you actually can work, put in your refraction, your ACD, and you get your sizing of the lens because this is based on the white-to-white measurement. I show you one case which demonstrates a problem. We did the same. We had an ICL implantation. The vault was 1,470 microns. The patient had actually good outcome, but he was complaining about photophobia, glare, and significant visual halos. And you see in green the vault of the lens. We exchanged the IOL to the actually lower diameter IOL, and we got a vault of 620. The patient was quite happy. Visual acuity was great. It was 20/25 with slightly amblyopic eye, but the patient 100% happy. So all the subjective photophobia went away. Optical phenomena significantly improved after the exchange. The patient is now very satisfied. Now, what do? We forget the low vault. 1 minute for this. I'm looking at the vault now. If I have just 20 to 30 microns of vault, I think that's enough because we have the central flow. We have not seen cataract formation with this, but this needs to be investigated. If we really need 250 as the lowest, or do we need 150? We don't know that. For the lenses which have the high vault, you can achieve optical phenomena, and you can also have an angle closure because we don't have an iridectomy, which is perfect for the ICL with a central hole. So there is a formula which we created with one of my fellows, actually two of my fellows. We're looking for this, select key parameters of ICL vault prediction by penalizing less relevant ones, reducing overfitting. You can access this formula on the internet, actually. This is a formula. Let me show what happens is when you put this in, they actually will predict the vault of your lens. If you have a sizing of 12.1, 12.6, 13.2, 13.7, you will see this outcome for post-optive vaulting. Most recently, our colleague from Salt Lake City, Mosifar, looked at the outcomes of the formulas, looked at regression model, trained in 115 eyes with our paper. Sorry, this is our lesser paper, which I just showed you. We trained a model of 115 eyes with 59 patients, and we had this formula developed. You find it in the internet. And the Mosifar paper is here, the ICL formula sizing, the accuracy of post-operative vault prediction and ICL sizing recommendations across all available nomograms. Includes everything what you find in the literature, by star nomogram, optimized white to white, and then you can see all these different formulas, analyze 209 eyes, and particularly what he found is that the AI formulas, the artificial intelligence formulas, Russo, Kamija, Kang, and Chen, were actually showing a good outcome and that they can actually achieve maybe even better outcome for your prediction. That said, there is from Roberto Zaldivar's group and Roger Zaldivar, they also had the ICL Guru. This is a development taking place in South America at the moment, also looking at automatically calculation sizing through AI. So my conclusion, we have good outcomes with the eye for myopia. ICL power and sizing calculation is important. Too low, you can cause cataract formation. Too high, you have optical phenomena, risk for angle closure, glaucoma, and you may have to change. Best formulas for the moment is sizing calculation. In my practice, we use the star nomogram, but we also add the Lesso formula or other AI formulas in order to get our outcome, in order to become better. With this, I thank you very much for your attention and having me here.
Thank you, Thomas, for that wonderful talk. And I think vault is the most important criteria. Any questions to Thomas? We can have a couple of quick questions. Can we have the mic in the front row, please?
I think the question was, how do we compare? Well, that's the Nakamura. So there are actually 4 AI formulas. If you want to use them, you have to go in the internet and get the lens. I just showed you ours, which you can access through the internet but punch in your data and you get it there. This is a non-proved, technology, because basically what happens at the moment is we always send our calculation to STAR. We calculate the lens, we get prediction, And that's the lens we usually look at, and we will order. But then we also go and take the lasso formula, take what we consider is the right thing. We're still under investigation how to do this in the future, but I would like to avoid the high vault and the low vault cases. These are very rare, I have to say. I would think that out of 100 eyes, I have maybe 2 cases of this. The rest is perfectly fine. And from 5 diopters, myopia and above, I always consider a phakic IOL to be my, my choice for refractive surgery. And we go down to 1 diopter if we have suspicious cornea. And sometimes patients just come for 3 diopters, as Robert Ang said, and they don't want to have any procedure on the cornea, and then we feel comfortable also to put it for 3 diopters. I think the world is changing at the moment. Phakic IOLs with the outcome we're seeing, the outcome is great, and so we will see what's going in the future. In general, we all have to work on this topic that we don't produce any complication with refractive surgery, otherwise patients are not following us. That's particularly in Europe. Still a lot of reluctancy against refractive surgery.
One question, please.
White to white. Yeah.
So,
And we can also use OCT. That's also, I think, included in the formula.
Can
Here's
you-
a microphone
Can you
if you
give the
want.
microphone there?
Thank you. Thank you, dear professor. I have a question. Did you have any experience on patients with a high refractive error and low ACD, low than 2.8? Because a young patient with high refractive error, high myopic, and has only ACD not more than 2.8. It's around 2.5 and etc. And what's your suggestion such these cases for this case? Thank you.
That's a very difficult question for me, or let's say to handle these patients. The reason is we have these recommendations in Germany, which I wrote with a team. So I cannot go to 2.5 and say, I haven't read these articles.
Unfortunately.
So, but let me answer. So, but if I have a case, let's say 2.75, 2.7, then I have to speak, and that's an 8 diopter, and the cornea is 450, so there's no other chance, just to make it up. Then I have to speak with the patient, is that an outlier, and can we have an informed consent? I don't like to do it, but occasionally, if there is a huge, huge need for these patients, we may go. I know that in South America, in other countries in the world, they go for 2.5, but I cannot, I will not say this publicly because my recommendation 2.8 and 3 millimeters would be for the hyperopes. In the US, you saw they even have 3 millimeters now.
Thank you for your reply. It's the most common among Asian people, so I asked about this question.
Flat,
Thank you.
flat anterior chamber and myopia.
Yeah.
Yeah.
Thank you.
one question, please.
So there's a need for a huge study for doing this. If 2.8 is the right anterior chamber depth.
Yeah, so normally for the sizing, we do white-to-white measurement in the operation theater under microscope, no. So since white-to-white measurement in the operating OTE is a little bit subjective, now do you suggest some other methods to corroborate or see or to find whether my measurement in the white-to-white is actually following the line, or some other measurements you can correlate for the actual sizing? You may get my question?
Not 100%, but I think it always goes to the same, situation. How do we measure
Yes.
the sizing, and what do we do? Usually there is a correlation from the white-to-white measurement. Now we have to say, white-to-white measurement is not always the same. You take the white-to-white, take it 10 times in the same eye, you get different white-to-white.
Yeah, that's right.
Because the prediction from where is white-to-white, is in the machines. That's a machine detection. If you don't do it yourself. We did it in the beginning with calipers.
Yes.
Just with calipers. But the calipers were then not to be as sharp as the Scheimpflug and so on. So I think that automatic devices are the way to go. The only thing they have to really measure correctly, you have to check. What I do is I always check my own measurement from my text. Take a look personally and see if the white-to-white measurement was really the correct measurement. And nowadays we have now OCT, so you can have more measurements if you want. You can spend a lot of time. I think that a reliable, good measurement is the most important thing.
Okay. Thank you.
I just want to add something, because if you have shallow chambers, as you talked about, I think it's always good to do a gonioscopy in these patients. If you think your angles are widely open, your 2.6 can become 2.8 easily, you can write up there. And if you have hyperopic patients, what we do at our center, if they are, we need 3. So if we have 2.8, we still go ahead and do a PI. Anyway, we have to do a PI. And we tell the patient if your chamber goes beyond, and we realize that in hyperopes, we do PIs, 2 PIs, following after a few months, chamber tend to go a little deeper as compared to the myopes. And I think a gonioscopy is a good way, and you can be safe if you tell the patient, yeah, this your angles are open, when still we're putting at 2.8. So I think that's what you should go about. And gonioscopy, I think, is very important in this one.
I think, thanks, Thomas, for that wonderful discussion. You want to add something?
Let me add this. I unfortunately have to leave you. I would really love to be here, but your program put me to give 2 more talks in another room, so I'm sorry. Happy to be here. This was a nice symposium. Thank you.
Thanks, Thomas, for that wonderful